We know that greater procedural volume usually improves outcomes. That's from PCI studies that were basically done with Femoral. Now, what about radial access? I mean, it's a little bit more tricky of a process. Maybe do more procedures have to be done in order to get the procedural volume up there? What we're going to look at today is a sub-analysis from a trial that you may remember, the Radial trial, and it's a new paper in JACC. It's evaluating procedural volumes as it relates to radial versus femoral access. And you probably recognize Dr. Sanjit Jolly, Associate Professor at McMaster University, Hamilton, Ontario. This is an interesting paper in JACC because this is a topic of what happens with femoral versus radial access in terms of procedural volume. Where's the connection?
Yeah, I think that's an important question. And in fact, if you remember in the main Radial paper, we saw that there was a benefit of radial access in high volume radial centers.
Right.
So we really wanted to understand that. So when we looked at radial volume and outcome within the Radial trial, this is very important because there haven't been a lot of publications looking at radial volume and outcome. We found an improvement. So for every increase in 50 radial PCI procedures, we saw a reduction of about 12% in the primary outcome. So wow. The more you did, the better you get. And I think that makes sense. I think the other important point is we found this benefit in high volume radial centers of radial instead of femoral access. One of the challenges was we have also seen a benefit in STEMI. And the high volume radial centers did more STEMI. So the question is, how do you sort that out?
Right.
When we adjusted for STEMI, we still saw a benefit for radial versus femoral access at high volume centers. So it was not just the fact that they enrolled more STEMIs, they did something else better. And the third most interesting part is we looked at door to balloon times. That's the fear.
Tricky.
Yeah.
Yes, exactly.
Is that we saw differences in door to balloon times about 13 to 15 minutes in the low volume radial centers, no difference in high volume. So there's clearly an expertise that if you're getting radial access at a high volume radial center, you're probably getting a better product than in a low volume radial center.
Did it matter where the individual providers and their number of procedures?
Yeah, and that's a good question, is that when we looked at the operator, high volume radial operators, we didn't see a benefit in the same way. But when we looked at a multivariable analysis and looked at outcomes versus operator volume versus outcomes, we did see an effect. Not as marked, but high volume radial operators still had better outcomes than lower volume radial operators in terms of their radial procedures. And the question is, well, why would you see a more marked effect as a center? And I think the answer may come to, imagine yourself, you're at a high volume radial center. The interventional fellows during the procedures are very comfortable with radial access. Right. You go to a low volume radial center and you have a fly-in high volume radial operator. The fellows that are working with that fellow probably don't do a lot of radial procedures, and so there's probably an important aspect of not beyond that single fly-in operator, but all the expertise at the center, including equipment and what they can do.
So what's the take-home message? What's the bottom line you want to get across in this paper from JACC?
The more you do, the better you get. And I think that's a very simple message. And I think that's a challenge, particularly in places like the United States where procedural volume is relatively low. But if you're going to do radial procedures, and I think we're going to see more of this, try to do, the more you can do, the better you're going to get. The issue is if something takes 3 to 5 minutes longer, is that clinically important? Probably not. The question comes if it takes 15 minutes longer, is that important? And the reality is it probably doesn't. 15 minutes, it's that scenario where the operator is being stubborn and clearly this method is not working, they need to switch. And I think that's common sense, and that's something that you don't need a trial to tell you. You need to give yourself a time limit, and if things aren't working, whether you're in the femoral or in the radial, you may need to switch to a different access site.
Well, it does appear that we have far more people doing radial procedures in the United States. It's growing. We're still not matching Europe, but it definitely appears like we are seeing more people feeling comfortable doing radial procedures.
The latest numbers I saw were about 16%, and you might not think that that's a lot, but that's come from 2%. So that's a huge growth in radial procedures in the U.S.
And there are some analyses that think that maybe the number could be even higher than that.
Yeah, I mean, I think if you look at the UK or Sweden that have national registries, you see about 60% of procedures radial access. And I think that may be the future of the US because it's certainly on the same trajectory on a year-by-year basis right now.
Well, it helps the more we know and the more we get studies that publish like this one to give us some insight into the whole issue. The March 18th issue of JACC is where you'll find the paper by Jolly and Company, analysis of the rival trial. For Cardiosource World News, I'm Executive Editor Rick McGuire.